All right, well, hello. Welcome to Val-You Based Care. I'm with Elizabeth at Haymarket, and we're here to talk about some of the ASCO studies that we're excited about, and we're going to be really super serious about this.
Yeah, we're switching seats now. I'm going to put you in the hot seat, ask you some very serious questions here, and we're going to do our best to pronounce these drug names right. Daraxonrasib has generated considerable excitement as a potential breakthrough in RAS-driven pancreatic cancer, particularly given the historic difficulty of targeting RAS biology in pancreatic adenocarcinoma. For ASCO attendees who may not have followed the earlier phase data closely, what makes the Rasolute 302 study such a potentially important moment for the field? And what key efficacy or safety signals will you be watching most closely when these phase 3 data are presented at ASCO?
Yeah, so coming from a community oncologist, I'm a doctor who sees all cancer types and treats all sorts of cases, all sorts of medicines. And so I definitely think of, with very high respect, the academic pancreatic cancer subspecialists who look at this as a huge achievement in the field, and they're probably excited about hopefully having some very interesting outcomes data, meaning progression-free survival oftentimes will come out in these types of big plenary sessions. Maybe, hopefully, even overall survival data. A lot of times we, as oncologists, feel like we may not get enough case events to have reached mature data to get the overall survival. But I think everyone's a little excited that maybe we'll actually, in the second line, have a new option that is a pill and is changing pancreatic cancer, because for the longest time we haven't really been able to do very much other than chemo. So I think that's where the excitement is coming from. At the same time, I also think about the safety signals, as you mentioned, where these novel agents can come with some more of the esoteric type of side effects, like ocular toxicities, or having to make sure that in the community, if we're going to manage something that is a little bit more subspecialist, like an ophthalmologist, how do we coordinate that? And so the novel technology is really promising, but I think also being able to manage the side effects is going to be an interesting part of this as well.
So there's the Proteus study, and that asks a major strategic question in localized prostate cancer. Can treatment intensification around surgery meaningfully improve long-term outcomes for men with the highest risk disease? A similar perioperative approach has become common in breast cancer. How significant is it to see this approach being tested in prostate cancer? And what specific endpoints or clinical signals will you be watching most closely in the final analysis?
Yeah, in terms of neoadjuvant strategies, a lot of cancer types, we've been putting things more medical systemic therapies up front rather than on the back end, because I think a lot of cancers we started out with surgery and then we did medicines thinking we got to reduce the recurrence rate. And then we're realizing we actually gain a lot of information by doing our medicines up front, because then we can start to understand the biology and watching the response. So the idea of pathologic responses, meaning we do medicines up front, watch what happens after surgery, is the cancer actually all gone? And then additional question of, do we need more therapy? This is a paradigm that's been entering a lot of cancer types. I think prostate is interesting in that we haven't really, to my knowledge, we haven't really used this pathologic response in prostate cancer yet. Like, we see it in breast cancer, we see it in rectal cancer. I think in prostate we haven't really quite entered that paradigm yet, because of probably a lot of the dynamics of just prostate cancer has been a very urologically dominated field, where a lot of times the urologists are managing first and then medical oncologists get introduced A lot of that has implications in the community in terms of referral patterns. So I think it's an interesting study, if anything, just to start getting that paradigm even wondering, is it even biologically applicable here?
The Libretto 432 study. The results of this study appear to represent an important evolution in precision oncology, moving highly selected targeted therapies like selpercatinib from the metastatic setting into curative intent treatment for early stage RET fusion positive NSCLC. How meaningful is this trial in terms of reshaping expectations around adjuvant targeted therapy? And do you think these findings further solidify the need for comprehensive molecular testing at the time of initial diagnosis rather than waiting for a recurrence?
Yes, definitely doing genetic testing. And that also highlights some of the challenges in community oncology of getting patients referred to a medical oncologist who understands how to do these tests, and then being able to do that in a way that's streamlined, because there can be a lot of different factors that are not even medical provider related, like getting the order in, and then how do we get the test results back, and how do we interpret and use it correctly in the right way. So it's a shift in going from the metastatic field where we traditionally use these targeted therapies, moving it earlier, which is always great, that we can be more proactive, but then having that component of what's our infrastructure, what's our medical system like. I think that's actually going to be the greater question. So, yeah.
The SARCO-41 study, it's particularly interesting because it reflects a growing shift in targeting tumor biology rather than treating cancer strictly by tissue of origin. D-differentiated liposarcoma is known to frequently overexpress CDK4, providing the rationale for evaluating abemaciclib, a drug many clinicians associate with breast cancer, in this rare sarcoma setting. What could positive results mean for patients with D-differentiated liposarcoma, as well as for the broader future of biomarker-driven drug repurposing in rare cancers?
Yeah, this is an interesting study because of exactly as you said, where usually in medical oncology we think of ourselves as, if we're subspecializing, then it's by tumor type, and we're very much thinking in terms of the biology of that tumor type. And so to cross over, it makes me even wonder, because I would wonder that origin story of how did someone even say, oh, I'm curious about abemaciclib in sarcoma. It makes me wonder if this person was, who first made that observation, was probably treating breast cancer and sarcoma and went, oh, that looks like they both responded. But I think it speaks to how we're getting more creative. And there's always been a lot of creativity in medicine, but I think of it like, it's not just can we make ever new drugs, but also what do we already have and how do we unlock what's really useful about those medicines?
Yeah, that really segues nicely into my final question here. Across several of these ASCO presentations, we're seeing increasingly sophisticated biomarker selection, targeted drug development, and smarter trial design. Looking ahead 5 years, which of these approaches or disease areas do you think AI could have the greatest impact on accelerating? Whether through biomarker discovery, patient selection, trial enrollment, or identifying new uses for existing therapies?
Yeah, it's always very tricky to make future predictions, because 5 years from now I'll look back on this and be like, wow, I was so totally wrong. But it's also really amusing because then it shows just how much growth one can experience in that time. And so I shall leap into the zone of looking silly and saying, I really like these ideas of taking medicines that we use traditionally in another field and then trying to apply it in another organ system, but we're really trying to answer that biology question, not so much like an organ, but more recognizing that our organ hierarchy is very much something we created so that our own minds can try to manage these diseases. But really, there's so much more complexity now that AI can help us with. And I'm probably not the first, definitely not the first or the only to be interested in AI twins, where we see how do we take AI to not replace humans, but to get to know humans really well, and then be able to go down these choose your adventure type of scenarios that clinical trials could never be able to do within a reasonable time frame. But in a digital AI twin, you could say, well, let's do it in this experimental way, or what happens if we put this is the intervention arm, or how would it look like if we took real human control, but then we altered all of these these things that have to be very well controlled in a randomized control trial. But when you're doing it in a digital frame, I wonder really how many almost near infinite arms you could be comparing at once, and be able to have AI hold all of that and still be computing and not fall apart. And so I think that is very interesting to me, of how do we take any drug in any cancer type and say, well, if I'm going to take this and put it in a different cancer type, how do we expect that to go forward? Kind of like how the Kaplan-Meier curve is a prediction based on taking so many events that have happened in the trial and then playing it out. How do we do that where it's not just the outcome, but it's the intervention itself, where we throw out the intervention and then we watch that play out? I feel like a little bit of science fiction when I talk, but I also am really excited that that could be the way that we're at least exploring both the science and the limits of the AI.
Mm-hmm. Sounds like there's a lot to be excited about at this year's ASCO. Thank you. Thank you so much for giving me your perspective on these studies. We're definitely keeping our eye on them, and we're excited to be there. So,
yeah,
Cancer Therapy Advisor, the team will be there, and you'll be there, and yeah, it'll be great. Thank you very much.
Thank you so much. I really appreciate you taking the community oncologist aspect of things. So thank you.
Yeah.